Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Hello, David, and welcome to all of our listeners around the country, around the world, throughout the galaxy. This is episode 492, and today we're honored to welcome Dr. David Healy, who is a medical doctor, a psychiatrist, a psychopharmacologist, an author, and one of the most thought-provoking voices in the field of mental health. You'll be able to tell pretty soon that he also has a wicked, funny sense of humor. He's one of David Burns' heroes and mine too, and we expect he'll be one of your heroes by the end of this podcast. Dr. Healy is a former professor of psychiatry at Bangor University in Wales, and he's a leading researcher on the history and the development of psychotropic medications. Dr. Healy found himself accidentally working on serotonin reuptake systems before the SSRI group of drugs came on stream. This research began for all the right reasons, and 40 years later, he might have come up with something interesting. That's a quote from Dr. Healy. In other words, he's best known for his groundbreaking work on antidepressants, including their benefits, risks, and the controversy surrounding them, particularly his research into the link between SSRIs and suicidality. He is committed to both scientific integrity and patient well-being. In between his work in academia, pharmaceutical companies figuring someone with his expertise on serotonin reuptake might be just the right person to help educate doctors on what to expect from their new drugs. And he was thus invited into their laboratories where the eyes of newts are added to toes of frogs to create potions that leave doctors and the public with not a thought in their heads except those put there by pharma. In addition to his academic work, Dr. Healy is the author of several influential books, including The Antidepressant Era, Pharmageddon, and Them Eat Prozac. He's also the founder of, I'm going to spell it, rxisk.org, a website dedicated to helping people understand the real-world effects of medications, and his own website, davidhealy.org. That's David, HEALY.org, where all contributions, especially disagreements, are welcome. So welcome, Dr. Healy, to the Feeling Good podcast.
It's good to be here. Maybe I should say it feels good to be here.
Yeah, thank you. I'm excited. I wasn't aware you were from Ireland. I've always had a soft spot in my heart for Ireland and Enya and all the beautiful music, and had a chance to visit there with my wife. We had a colleague, Tony Bates, when I was in Philadelphia, working at my clinic, a psychologist. And then
I think I knew Tony Bates once upon a time.
Oh, is that right?
Small world. Yep.
Yeah. And I remember the smell of peat. We were on the ocean and we had a little fireplace, and I'll never forget that smell. We actually took some back to the U.S. on the plane and had it for a little while. How did you run into Tony Bates?
I think we were both working in the same unit at one point around 1984 or so.
Oh, okay. Mm-hmm. Yeah. Well, tell us about yourself. I've only seen you from a distance and through the eyes of David Antonuccio and others, but I'm aware that you were doing some really fantastic research and pointing out a kind of, I guess, inconvenient truth that the things that were being called antidepressants are having a significant stimulating effect in activating suicidal thoughts, suicidal urges, suicidal feelings. And, from a kind of simple common sense point of view, it's hard for me to think of something as an antidepressant when it's a pro-suicide type of thing. But I know you had an appointment to go to, I guess, Toronto, University of Toronto, and you thought people would be very excited by your findings. I almost make that mistake as well. And then you pointed out that there's a significant suicide risk associated with antidepressants, as here I am, and here's the kind of thing I can do. And tell us what happened.
Well, that's not the only problem I've had.
No, that was the start of many.
Yeah. The key thing is, I don't usually tell people that what you need to know is the SSRIs cause people to commit suicide. And what I did in the lecture in the University of Toronto was to say, look, I've seen company documents that you haven't seen. I mean, that we all should be able to see. And based on these, I know that companies think their drugs can cause people to commit suicide, but most of you in the audience probably won't think that. The issue isn't just can the drugs cause a problem. The issue is the information that's being withheld from it. We're not operating on a level playing field. It's not really science. People are just getting to see a bit of the data rather than all of it. Now, 20 or 30 years later, when I moved back to Canada, there was still a lot of bad feeling about all this. The Canadians still don't think the drugs can cause a problem. And innocently, I was hired to help deprescribe some medicines. Now, not just the psychotropic medicines. It was more a case of, you had a lot of people who were on 10, 15, 20 drugs, including 10 psychotropic drugs, even young people. Yeah. And the issue wasn't trying to get them off all of these things, just a reasonably gentle question. Don't you think we could reduce these from 10 to 8 or 6 maybe? But I was told that Canadian doctors and patients, I was told, but I'm sure this is wrong, Canadian primary care doctors, when they refer to someone like me, expect people to get more diagnoses and more pills, just like if they refer to a clinical psychologist. They aren't surprised if the person gets CBT, and if that doesn't work out, DBT gets thrown in and IPT gets thrown in and XBT or whatever, They seem to see the pills as much the same thing. You can't really do any harm if you just throw more things into the mix. So this was medical consumerism, and I was told that, we don't want you here, basically. And one of the interesting things about it, I have an interesting article that I can email on to you and that people listening in may be interested to read. One of the oddities is it's become a privilege of wealth to get off treatments. If you're in a public health system like you're the Canadian one or the UK one, you get put on more and more drugs. And increasingly, younger people are opting to get themselves on more and more drugs. You really have to be wealthy and able to pay for a doctor to help get you off drugs these days.
Mm-hmm. To pay for therapy too.
Well, even without therapy, it's just getting out of the mental health system takes money and influence, basically.
Yeah, when I was, I started out like you in psychopharmacology and doing research on brain serotonin systems and thinking this was all going to be wonderful, but at least the training that we had. I was in Joe Mendel's group at the University of Pennsylvania, and we were taught one medication at a time, and maybe two in an emergency. Like if someone's on bipolar and lithium and they're getting super high, you can add some Mellaril or Thorazine and cool them off so they don't have to be hospitalized. But then, even then, some people were starting to do crazy things, add more and more drugs. And we used to call them psychopharmacology cowboys. And it just kind of taken over the field, and it blows my mind. And we always thought if there's a side effect, lower the dose, keep the doses as low as possible if you're going to use them. And then I started saying, well, people give up drugs for the side effects and drugs for the side effects of the drugs for the side effects. And you get these people on, so many pills. And as I mentioned to you in an email, I used to prescribe antidepressants if patients asked for them because there was so much advertising for them. And I thought, well, if I'm treating someone with depression and God forbid they commit suicide and I'm sued, I don't want to have to go to court and defend myself. Why didn't you prescribe antidepressants? Hang him, folks. So there were thousands of times that I was managing patients with antidepressants, but I never saw much from them, almost nothing. And I used to ask myself, there's fraud here somewhere, because I go to the American Psychiatric Association meetings and there's a symposium with 1,000 doctors and everyone's being fed 4-star gourmet food, and they're talking about some new antidepressant, and they're saying these things are going to, cure 85% of depression. And I said, well, why don't any of those patients ever come to me? I'm not seeing anything like that at all. I can't remember any patients that have been cured by antidepressants. But,
Let me quickly ask you a question.
Yeah.
When were you in Joe Mendel's lab?
Well, let's see, it would have been in the early 1970s that we moved out to from California. I had gone to medical school at Stanford, and I dropped out for a year twice because I never wanted to be a doctor. I shouldn't have gone to medical school. But then I went to Highland Hospital. I found someone that would take me, and I really kind of fell in love unexpectedly with medicine. It's a big county hospital in California, and the people were down to earth, and I really found a love for medicine. And after a couple of years there, one of the faculty said, you shouldn't be at a place like this. I found this ad for this research residency at Penn, and you could apply for it. And I said, well, no one at Stanford, no one would give me a letter of recommendation. I was such an awful medical student. And she said, well, I've seen what you do, and, I'll write a letter for you. So I ended up there, and I'd gone from being a totally lazy, horrible medical student to just working like crazy. But I do remember the first thing I did, he gave me an assignment to write this paper. They'd given L-tryptophan in a double-blind study to the people on our depression research unit at the VA. And, L-tryptophan, as you know, goes into the brain and it's converted into brain serotonin. And so the idea was, well, if there's a deficiency of brain serotonin, then this L-tryptophan should be improving the moods. But then there was no difference in the two groups. Neither group had improved. And then I got frustrated, and I said, well, maybe it's not enough. So I purchased a kilogram of pure L-tryptophan from the Ajinomoto Company of New York, Incorporated. And in the hospital, we put it into half normal saline at the maximum human concentration, so I could get 10 or 20 grams in 30 minutes. And a lot of the veterans volunteered for that. And even that didn't help their mood. Some of them fell asleep. And I asked Joe Mendels, and we wrote up that paper for the archives of general psychiatry saying that the L-tryptophan does not do anything for the moods of the depressed veterans. I said to him, why are we studying serotonin? Because I've been reading reprints. They were stacking up reprints, thousands, and I would just go through them trying to get caught up and figure out some research to do. And I said, why are we researching, serotonin, giving out all these drugs that affect serotonin? Our research shows that serotonin has nothing to do with anything. And he says, don't rock the boat, David. We've got a good thing going here. You're already giving lectures all over the world on brain serotonin. And then I won the A.E. Bennett Award for my research on, 5-HIA excretion and challenged the work coming out of Arminio Costa's lab. And so he said, you've got it made. And I said, well, I don't want to have it made. I got in this only to try to help people. And I don't want to spend my life on this thing. It's not going to go anywhere. And then that's when I migrated over to Beck's unit and learned about cognitive therapy and got excited about that and left the university. But
let me tell you why I've asked, David.
Yeah. Mm-hmm.
Okay, yeah. Okay, so Joe Mendels was one of the first investigators for Pfizer's first Zoloft trial.
Yeah.
This was in 1983. And there was one particular patient who was in the trial who was doing well on his Hamilton rating scale score. But one of the people in the research team had obviously talked to him before, as opposed to rating him, had talked to him as a human being at some point, and actually passed him by one day and figured he's different. This isn't the way he was, so he talked to him again. And he found out that while the Hamilton rating scale score had improved, the man was now feeling suicidal and homicidal. He was going to kill someone else first and then kill himself. So they dropped him out of the trial, coded as nausea, not as suicidal.
Wow.
Yeah.
Okay, and his improving Hamilton rating scale score, I'm sure, was as using the last observation carried forward approach. He became one of the people that helped get Zoloft approved.
Yeah. We sense that also. That some of the people in the lab who had integrity began to realize that that things aren't adding up in many ways here. And I don't want to say more, but
No, sure. But the point I'm making isn't so much that I'm doubting Joe. I mean, I think he always looked quite good to me. It's much more a case of what the companies can do with the data behind the scenes.
Yeah, right. And it just is sad how corruptible humans are. We're seeing it in our politics now, and it's like it's jaw dropping. And you'd think from an intellectual integrity point of view, that'd be the one place where truth would win out. I have been courageous like you and spoken up like you. I've tried to, not offend too many people. Now that I'm getting old and cranky, I'm enjoying getting offensive more. But, when I moved back to Stanford from Penn after 20 years, I tried, I had to wait till everyone who remembered me as a medical student had died, because I knew that if they remembered me, they'd never let me back at Stanford, even on the voluntary faculty. But when I went back, I mentioned a little experiment I'd done at Penn, because I'd been questioning the value of these mental disorders in the DSM. Are these real mental disorders? Because once you do that, well, then you have to have a pill for some kind of mental disorder. So although I was in private practice, we paid to have every patient have a SADS interview before we started treatment. And you remember those horrible things. Mm-hmm. Yeah, and to apply all of these DSM diagnoses. And then when I had a new patient, I got the printout of all of these so-called, mental disorders. And I found that when I looked at the outcome of my patients, the only thing that predicted it was simple, brief rating scales on how depressed or anxious they were feeling. And the DSM categories added nothing to the prediction of change or the understanding of change. And so that's the way I practice. I always measured the symptoms at the start and end of every session. And then I could see who's improving, who's not, and modify my approach. And it was, that was very, very exciting. But when I went to Stanford, I gave a workshop there they wanted to develop cognitive therapy on the inpatient unit. So, I gave some workshops and helped them set that up as part of my volunteer work. But I mentioned in passing that research that I had not seen that these DSM diagnoses, some of them are real. Schizophrenia is real. Bipolar is real. I mean, there's nothing made up about that. And they're tragic, real, brain abnormalities. But I said, for the most part, I haven't seen any real value from going through all of this DSM, signing all these mental illnesses to people. And then I thought people would be excited by that. And 3 days later, I was called before the Stanford Ethics Committee. I guess some of the faculty got enraged that I was challenging. I didn't think of myself as, challenging something that was going to threaten somebody. But I guess your career is you've gone out there with the tremendous courage and,
Well, I don't think it's particularly courage. No, I think I've got a fatal flaw. If people tell me, look, this is white and it looks black to me, I'm inclined to say, well, no, it looks black to me. So,
yeah, right.
Dr. Healy, was there a specific patient or a case or a moment in your career that made you realize something wasn't adding up in your research with SSRIs? Was it that moment that you were talking about in that last research, or was there a patient? What sparked your interest in the criticisms and the analysis that you've given to antidepressants?
Yeah. I haven't changed my views at all. Mm-hmm. Okay. At any point, there was no particular patient that actually caused me to say, hey, wait a minute here. It was much more a case of, let me explain. What I said to you early on, I went in to look at the serotonin system and work in a lab for all the right reasons. You need to remember that at the time I was I was probably about 27 or thereabouts, and...
what year was this, roughly?
This was 1979, 1980.
Oh, okay. Yeah. Wow.
And so you have to remember a youngish man asking, why are you doing this? Because I was going to end up not really being paid much money at all compared with a medical job. Okay. And the answer I usually gave people was, well, I'm really interested to find out how the mind fits into the brain. Now, if you know young men, that's code for, I want to understand women. Okay. And I can't say 40 years later that I do understand women, but one of the things I think I do understand is that most of our mind isn't in the brain at all. It's in our bodies. And the SSRIs are awfully good tools of being able to explore what happens in the body, in the peripheral nervous system. there's very little serotonin in our brains. Way back when David was doing tryptophan work, I was also looking at tryptophan and thought everything was going on in the brain. The SSRIs are wonderful drugs to test our sensory nervous system. They actually affect our eyesight, our hearing, our sense of touch. They've helped us maybe discover sensory receptors we didn't know were there. So, one of the extraordinary things is we can now look into brains, so we can see the brain in operation. We can test the motor nervous system, but we know nothing about the biggest organ in the body that's right in front of us every day. It's skin, touch kind of sensation is something that we know very little more about than we knew 100 years ago. And the SSRIs changed that fairly dramatically and fairly instantly. So, they are a tool, but let me go back and add something else in here, which is one of the things that I was thinking about saying to you is I've learned more about what these drugs do from the patients who've been on them, the people that have been on them. They report things, and I'm inclined to listen to what they say. And I've learned much more about what these drugs do from people coming in and talking to me than you can find in any books or articles. And we set up risk.org. That's the word that you weren't able to pronounce earlier. Okay, to get people to report on what they noticed when they were on pills. And we created a system where they could fill what we call a risk report, which gave them the kinds of questions an expert would ask you if you had a problem on a pill, trying to work out, has the pill caused this particular problem? And the idea was this would equip them with a report from a website which had all the expert questions on it, and it would make it easier for them to go back and talk to the doctor who put them on the pill and say, look, I think this is actually happening to me, because we knew people were a bit nervous about this. But even equipped with an expert report, they don't do that. Most people feel too threatened. They sense that the doctor is likely to get nasty if they talk about an issue on the pills, which in particular isn't in the drug's label. They're asking the doctor to believe them, and they sense he or she won't. Now, this comes out very interestingly with clinical psychologists. A lot of them in the United States say to me repeatedly that they can see the patient on these pills is actually having problems, maybe falling asleep right in front of them, or they're having a range of other problems, but they don't dare talk about what they think the drug is doing to the patient for fear that the patient will say, Dr. Antonuccio or whoever was saying this about the pills to me, and David Antonuccio, for instance, will get a phone call from some doctor saying, you're not licensed to practice medicine. Stop. Now, we're not doing science if we have that kind of situation. Doing science is all about trying to come to a consensus on the observables. And most of the observables in this case are things that are observed by the patient. Some patients will actually try to fool us, but if they have a problem, that's rare. If they bring a problem to us, it's because they have a problem and they're trying to see what the answer might be. And if we don't listen to them talk about the observables, if we're trying to follow guidelines, books which say this, that, and the other, we just aren't doing science. If there isn't a clinical psychologist also in the room interested in the behavioral effects of these pills, we're just not doing science. So we have a system that doesn't just get a lot of people on a lot of pills and give people loads of diagnoses that they don't really have, but it's a very violent system.
It's sad and tragic what you're saying, and it's just like the conflict between marketing and money versus truth and integrity and compassion and working to be helpful and just I think people don't appreciate, a lot of people don't appreciate the extent to which there is this, attempt at thought control when you've got something, selling, making billions of dollars in sales and profits. I have a lot of questions for you, but just I'll keep them real short and simple. One of them is, I want to hear about your research on the influence of SSRIs on, sensitivity and sensory processing, but also on a more global thing. Are you of the impression that antidepressant medications exist?
Well, the older drugs definitely could help melancholics. And that's a severe mood disorder, okay, which is a high risk of people going out to commit suicide. And they can get people well, which reduces the risk. But doctors 60 years ago, when these drugs came out, were also able to say openly, these drugs are going to save lives, but they can also cause people to commit suicide. Okay, so there was a much greater openness back then and willingness to work cooperatively with other professionals and the patients. That's what we've lost. Okay, so the SSRI group of drugs were made, first of all, because Freudian therapists looking at patients put on the older drugs said these drugs are having impact on the transference reactions.
On what?
On the transference reaction.
Oh, yeah.
It's a very Freudian term, okay?
Yeah.
And we now understand that means there's reduced emotional reactivity on these pills. But it was that observation from Freudian therapists that led to the creation of the SSRI group of drugs to try and explore what the effect on the transference reaction was. And what you have is a group of drugs which are essentially anxiolytics. They're not particularly helpful for people who've got a severe mood disorder like melancholia. In fact, all the trials done on all the SSRIs were done on people who were mildly depressed, who could be diagnosed instead as being anxious rather than depressed. It certainly weren't melancholic, and there's no evidence that any SSRIs actually help severe mood disorders.
Yeah, right.
Really? That's amazing.
Yes.
And that's pretty unknown. I've never heard of that before.
Well, there's a lot of things that we all think because they're just repeated the whole time. And one of the things that you hear repeated the whole time is antidepressants, and by this people mean SSRIs, are good for severe depression. They haven't ever been shown to work for melancholics in a clinical trial, or people who are hospitalized for their mood disorder. When they were brought on the market, they were given to primary care patients who were, marginally depressed, if depressed at all.
And by the older meds, are you talking about the tricyclic antidepressants?
Yes.
We'll keep talking. I'm just fascinated by everything you're saying.
Well, I think the key issue there, just talking about the older drugs, is, it isn't what we actually know about the drugs. There are issues here that we can actually talk about for ages. But one of the big problems we have is why 60 years ago could people talk openly about the hazards and they can't do it now? We're told on all, and it isn't just the antidepressant group of drugs. It's almost all medicines We're told that you don't want to actually mention that these drugs could cause a problem, that they could make you suicidal, that they could interfere with your ability to make love, for instance. But doctors could see that 60 years ago and were able to talk about it. But we can't talk about these issues now because we're told it will generate treatment hesitancy.
Treatment what?
And treatment hesitancy.
Oh, treatment hesitancy.
It will actually make you hesitant to have treatments, whether antidepressants, vaccines, or whatever. We can't talk openly about these things.
That's scary.
It is very scary. And it's very hard to see how to turn it around.
Mm-hmm.
Have you run into, I guess starting in Toronto, you ran into some opposition that was affecting your career, your position, that you had a tenure track position offered, and it was suddenly withdrawn, as I understand it. And have you been targeted in any active way that you're aware of by the drug companies to try to silence you in your raising questions about the side effects and toxic effects and missing effectiveness effects of the various antidepressants?
Yeah, no, I think people on the outside can get a mistaken view about what's going on. The people who've given me the biggest problems are my clinical colleagues, not the pharmaceutical industry.
Really?
Interesting.
The pharmaceutical industry don't want to hear that David Healy's been fired from a post in the University of Toronto because he said exercise can cause people to commit suicide. They don't want that to happen. It was a clinician called Charlie Nemiroff, who was a fairly famous doctor, who took it upon himself. Yes. Yeah, so he was the one that organized for me to get fired. But let me give you a little vignette that you may find interesting. I was giving a talk a few years later in the Institute of Psychiatry in London, which is a very famous unit. It's the center of UK kind of psychiatry. It's where all the experts are and things like that. And I was asked along to give a talk about SSRIs and suicide. And before the talk began, this very attractive woman came up to me and said, "You're David Healy. I'm so pleased to meet you." And I said, "Yes, I am." And she said, "Well, I'm the marketing director for Prozac in the UK. And you're doing more to sell Prozac than anyone else is. Industry can use controversy to sell pills."
Wow.
They're not always hostile. I mean, they can use me. So, the trick for me is to try and work out what on earth can I do to discombobulate the pharmaceutical industry. It's very difficult to do it.
Interesting. Yeah, wow.
Well, how have clinical psychiatrists criticized you? You said most of the criticism is from clinical people.
Yeah. The extraordinary thing about all this is you can meet people who worked in industry and they'll say openly to a bunch of clinical psychiatrists, "Look, you guys don't have a thought in your head that's not put there by us." And the doctors don't get insulted. They think it's a joke. They experience themselves as having their own mind. These thoughts aren't put in their mind. They're the ones that they've come to themselves. And when you get a person like me, I guess, not going along with the party line, they're the people who get very worked up about it. It's not the pharmaceutical industry. They know I'm talking about the company line, so they can't really object. But clinical people do, and this is a problem that I've referred to as delegated narcissism, which is, when we're young, when we're children, we look up to our parents because they're the ones who know everything. Later on, when we grow up a bit, we know they don't know everything, that they are that much different to us. When times are uncertain, we delegate narcissism to dictators and gurus and things like that. The industry put a lot of work into getting us to delegate our narcissism when it comes to drugs to the FDA. They've been made by industry into the father figure that's there to keep us safe. And whatever FDA says about the drugs, that they work well and they're free of this problem or that problem, there's a lot of doctors will end up saying, well, yes, that's the case. But FDA aren't scientists. They're just bureaucrats. And when doctors end up figuring we have to go along with what FDA says, and FDA, in essence, don't say anything. It's the companies that write the drug label. FDA just look over the paperwork. So when we've got doctors saying, well, FDA has approved this and FDA haven't said the drug could cause this problem or that problem, therefore we think this drug works because it's been approved and we think it really can't cause problems. So this is a very odd kind of position that Freudians knew about during the 1960s. Doctors trained in the United States in the Freudian approach were the ones who introduced me to the idea. This is what's going on. Doctors are increasingly delegating narcissism to a group of people who, up till the early 60s, they would have referred contemptuously as bureaucrats.
Yeah, I have an idea about where some of this comes from, and it's pretty cynical. And I haven't done my homework. I've got to, after the interview, ask AI for the specifics. But I do recall when I was at a faculty meeting at Stanford. And I don't go to faculty meetings hardly ever, but it was something for the voluntary faculty. And I was asking a colleague if someone has a brief psychopharmacology maintenance session, because, I was doing psychopharmacology plus cognitive therapy for years. So I've managed an awful lot of people on all kinds of medications, including the antidepressants. And I know it takes about maybe 1 minute to 90 seconds to manage someone's medications in a session. Are you having any side effects, and do you need a prescription refill? And, it just takes a few minutes. And I said, if you, because I don't code, I haven't charged, for anything for 30 or 40 years. But, I said, suppose you use that coding for the brief. I guess it has to be 5 or 10 minutes or something like that. And then what's the reimbursement? And this was 15 years ago. And I think he said, if I could be way off on this, but I think he said $180. And so now in today's dollars, that would probably be, double that to, I know at Stanford, when they have psychiatric residents seeing patients, they're charging like $900 an hour or something like that.
Gosh. Mm.
But this would be just for a brief one. So if you're a new young psychiatrist starting out in practice and you use that, you can probably get $200, $300, $400 for a 5 or 10 minute session. So then you can schedule, many an hour, 6, 8 to 10 patients an hour, and then pretty soon you're looking at a salary of, I guess $1 million a year or even more. And it doesn't take that long to learn how to prescribe antidepressants. You don't need 4 years of medical school. You need maybe an hour and a half. I could teach people how to prescribe and manage antidepressants really in about 15 minutes. Because I just say, well, give any antidepressant you want because they're all about the same, and just stay at the lowest dose, and you'll be good. There's no dose response effect, as there would be for real meds. But the point being that's a huge draw. And then I've been offering free psychotherapy training in the new team CBT that I've developed. And it really takes years for people to learn how to do it. It's very sophisticated, and most of the people who try to learn it fail, to be honest with you. But it takes a lot of discipline, and so many of my students, some of them psychiatrists, have learned how to do it, and so they can see people and get really fast results. And one of them, after he opened his practice, his name is Matt May, and he just became like a magician, getting almost a total recovery in depression in 1 or 2 or 3 sessions with most of his patients without medications. And I do these Sunday hikes with my students, and he called in the middle of the week and said, I need to have a hike. Could I have a midweek hike? I said, sure, I'd love to see you. Come on over. And he had just opened his practice, and we started hiking, and he started crying. And I said, what's wrong, Matt? And he says, David, I can't pay my bills, and I'm falling farther and farther into debt. And I said, well, what's the problem, Matt? And he said, well, you're the problem, because almost all of my patients, I see them for maybe 4 sessions max, and then they feel great and they're ready to terminate therapy. And I said, well, Matt, that's a good thing. We'll talk you up and send you a bunch of referrals, and all of a sudden now he's loaded with patients and he's doing great. But it's money is very corrupting to people, and to even, if you're going to do a kind of psychopharmacology that's thoughtful and honest, I guess that's good in a sense, but it just seems to me like it's a money-making system, kind of like a chiropractor. And some of chiropractors are great that I've heard, but they want to get as many patients through their system and get as much income as possible. And I think that's very, very, very corrupting to people. And I mentioned at a Stanford meeting, one of the top psychopharmacologists, there was some reception or something for the new residents, and I said, what do you think about this research of Irving Kirsch, that the Emperor's New Drugs, that the antidepressants, SSRIs, don't seem to have much, if any, meaningful clinical effect above and beyond their placebo effect. A placebo will give you 8.5 points on the Hamilton, and the SSRIs will give you 10 points. And that 1.5 is kind of negligible. And he says, oh, well, I haven't bothered to look at that. Everyone knows that antidepressants work. And it's like, well, this guy isn't going to be worth talking to. But I just think there's, kind of a blind spot. But sometimes our blind spots are motivated by, if you're making a lot of money, and then what are you going to do if you decide to stop doing that?
Yeah, but in this case, of course, if you're being motivated by money, it can make a huge difference to loads of people. But a lot of doctors would say they go by the evidence and they're rational.
Yeah, right.
They've been sold the idea that randomized controlled trials are the height of rationality.
Yeah.
That the best scientific approach towards drugs or therapy, and they aren't. If you take LSD and put it into a randomized controlled trial and compare it to placebo, it will come out the same as placebo. The good trips and the bad trips will average out, and you get very little difference to placebo. If you say to people, if you say to a doctor, look, hey, there's not much difference between LSD and placebo. It's really just a placebo effect. The doctor's not going to believe it. The person who's had LSD in the street isn't going to believe you either. And it's the same with the SSRIs.
But what's the LSD for? But why are you taking the LSD to reduce your melancholia? Are you just taking it for fun? I don't understand that comparison.
No. If we put it into a clinical trial, a randomized controlled trial, the good trips and the bad trips will average out. I mean, if we have the right rating scale picked, you'll get LSD looking just like placebo. And SSRIs as well look pretty similar to, placebo. But behind the figures, you've got good trips and bad trips. You don't have a lot of good trips, and you do have a lot of bad trips. But the idea that these things don't do anything, good or bad, is a mistake and kills.
Oh, yeah, absolutely. Yeah. The SSRIs are thousands of times more powerful, I suspect, on serotonin receptors than the early drugs. They
yes, absolutely.
Powerful on depression. And I think that's your area of knowing all about the effects and side effects of these SSRIs. And if you want to talk a little about that, I'd love to hear. But anything you say, I'm just eating it all up and appreciating it.
Yep. We can people have done randomized controlled trials in people who are mildly depressed and given them either benzodiazepines or stimulants or nicotine or antipsychotics or tricyclics or SSRIs or norepinephrine reuptake inhibitors that don't inhibit serotonin at all. And they all look the same.
Yeah, sure.
Randomized controlled trials don't tell us anything about what drugs do or how to treat the person right in front of us. We need to be able to say to people, look, I want this drug to do this or that. Like in the case of the SSRIs, I'd say, look, I want this drug to mute your sensory reactions to just the right extent that you find helpful. If I can't say what I want the drug to do to get you well, as opposed to saying, look, these drugs are just going to get you well, okay? If I can't specify what I want the drug to do, then people aren't put in the kind of position that will help them get involved in the therapy. They know what to look out for. They're able to tell me if the dose is too high or too low, if this suits them or not. If I don't have that kind of relationship with the person that I'm putting on a pill, then, I'm going to end up killing them. And we've got this myth at the moment. The SSRIs work on people within a day or two. We did this interesting experiment in the unit that I used to work in North Wales, where the medical and nursing staff volunteered, roughly 20 of them, volunteered to take either an SSRI for 2 weeks or a norepinephrine reuptake inhibitor for 2 weeks, and then to be crossed over to the other one. And the idea was, do these drugs all do the same thing? Or can they put in words what the difference between the SSRI was and the norepinephrine reuptake inhibitor was? And the answer was they were able to put the differences between the two drugs in words quite well. But the interesting thing behind the experiment was none of the patients in the unit were told that the medical and nursing staff were involved in taking these drugs. And 48 hours after the trial began, one of the patients came up to me and said, "Is that doctor on a drug?" I said, "Yes, he is." And he said, "Is he on an SSRI?" And I said, "I don't know. We'll have to wait till we break the blind." It turned out when we broke the blind, the patient was on an SSRI. No, the doctor was on the SSRI. The patients can spot what these drugs are doing. And it's not placebo. They can clearly see when a person's made mellow on an SSRI, a person who's usually a bit more irritable and is now mellow on this pill. And they can see the effect within 1 or 2 days of it on the pills. Now, the problem at the moment we have is most doctors are trained to think these drugs can take 6 weeks to work.
Oh, yeah, right. That was the myth.
So you've got the situation now, which is a lot of people get worse on an SSRI, and a lot of doctors say to them, this is just normal for SSRIs. You've got to hang on in there for 6 weeks, and the drug will work. There is no evidence from clinical trials that a bad trip on an SSRI will at any point turn into a good trip. If you're having a bad trip on an SSRI, you need to be got off this drug as quickly as we can.
That is super interesting.
Yeah. Tell us, what are these effects that come in after 2 days?
Well, the ones that come in after 30 minutes is your genitals get numb. This can be helpful for some men who've got a premature ejaculation problem. But it's a thing that actually happens to roughly 9 people out of 10. With almost all drugs, there's at least 1 person out of 10 where the drug does the opposite thing to the thing that it normally does. But okay, so this genital numbing correlates very, very closely with what the patients describe as emotional numbing. So you, on the drugs, you'll become emotionally numb within a day or 2. And this may suit you or it may not suit you. One of the big reasons it isn't going to suit you is that in the clinical trials we've done of drugs like Prozac, the companies were so nervous that they wouldn't be able to show that the drug worked at all, that they put people on a 20 milligram dose of Prozac, which is on the verge of being toxic. Lots of doctors think this is a low dose, and they put you up to 80 milligrams of Prozac.
Oh, yeah, I know. That's horrible.
Lilly, in fact, did an RCT around the time Prozac came in the market that they didn't tell anyone about. They did a 5 milligram dose, and it worked just as well, if not better, than the 20 milligram dose. And internally, the company was writing emails to each other saying, what are we going to tell people about this?
Mm-hmm. Right. So you had written about the post-SSRI sexual dysfunction. Is that what you're talking about, the numbing?
Well, no. Anyone who gets on an SSRI will become genitally numb. There's a proportion of people who, when they come off the SSRI, you'll also remain genitally numb while they're on the pills. There's a proportion of people, when they come off the drug, the problem gets worse and can stay for the rest of your life.
Oh my gosh. So when you're taken off and you're however you're taken off the SSRI, you can have the problem for the rest of your life. And this is particularly a problem, isn't it, for teenagers?
Well, it's a problem for everyone. Every so often you'll hear some older people who will say, well, I'm old now, so, hey, I can live with it. But I feel awfully sorry for kids in their teens. The fact that if you can put in these drugs pre-pubertally, we have people that get in touch with me who say, I have never had an orgasm of any sort.
Yeah.
And this isn't discussed between doctor and patient, you're saying? This is, no one is saying to the parent of this young teenager, oh, I would like to prescribe an SSRI. Your child is depressed, blah, 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 but, look for a risk of suicide. And then we also have this problem with genital numbing, and that might turn into a lifelong problem.
Yeah. And when you look at what the government say about these things, when they actually produce materials, they don't mention these problems either. And if you do what I've done and try to get in touch with the government in France, in the UK, in the United States, and ask, why don't you mention this? They say, we don't want to deter people from seeking treatment.
The hesitancy.
Yeah.
Antonuccio said that's why they only put the suicide warning for teenagers. They didn't put it for adults because they were rationalizing, well, this might discourage some people from taking the antidepressants, the SSRIs, and then not getting the benefit.
But it also actually applies to the medium. If you go back and look 20 years ago in the United States, when people were being killed in a school shooting or things like that, you'd have lots of articles, and it would be mentioned on the TV news that the shooter was on that controversial drug Prozac.
Yeah.
10 years ago, that disappeared. You'd have a mention of, well, the shooter wasn't treated for mental problems. And you have to work out he's likely on a pill. Now you're told, and the media say, we've been told not to deter people from seeking treatment, so we don't talk about any mental illness you might be treated for, and we certainly don't mention the name of any pill.
Yeah, it's so interesting, so disturbing. Yeah, I have two questions for you. Number one, you mentioned emotional numbing. What does that mean in terms of negative feelings like depression and anxiety and inadequacy, etc., or positive feelings of happiness and joy and satisfaction and so forth?
Yeah, it means both. The good feelings that you have about things will be numbed. You remove the joy and sorrow from life. Everything just becomes kind of bland.
Okay, yeah.
Now, it can also, as opposed to just being numb and becoming bland, things get muted. You've got less happening in your mind, less thoughts, less imagery, less emotions generally.
I see.
Let me give you a very vivid way to explain it, and this isn't going to sound all that great in ways. Back 5 or 10 years ago, when in Iraq, people were chopping the heads off people and putting videos on the internet of all this happening, people on SSRIs that I know of used to go and watch the videos in order to be able to feel something.
Oh my goodness. That extreme, they would have to go to that extreme to feel something.
Yep. Mm-hmm. I'm sure there's a number of people that I know of who've ended up in jail for child pornography. And that's again because they're trying to find something that will make them feel.
You've mentioned good and bad trips on SSRIs. Can you describe that a little bit more? I know what good and bad trips on LSD are because it was when I was a medical student, it was available here, Sandoz LSD in the mid-1970s, and it was coming out of the VA in Menlo Park. Ken Kesey and others were volunteering to be research subjects, and then they got it. And so I didn't take it a lot of times, maybe 5 or 6 or 7 times, something like that. But I certainly know what a bad trip is, and also, how amazing it can be as well. But I'm sure with SSRIs, you're referring to very different kinds of experiences from that.
Well, it's very much a case of if you get the right amount of emotional muting, and you're under stress, there's all sorts of things going on, and you want to be numbed a bit, and you're the kind of person whom this suits, that will give you a good trip. Now, my hunch is it's more introverts who appreciate this kind of feeling as opposed to extroverts. The people that I know of, that I've met who've gone on to commit suicide have been extroverted. people who like to, as it were, feel the other people in the room, closely sense the other people in the room, to have feelings about them, as opposed to an introvert. And this is the Jungian sense of the word, where the extrovert is the person when they're anxious and has problems, shares the problem around, gives a mom a problem if they're a kid. They talk about, Mom, I've got a pain in my tummy and I don't think I can go to school tomorrow. The introvert is much more the person who will be on their own and give themselves problems. They'll be up in bed and they'll ruminate about the ghost beneath the bed or outside the window or whatever. They won't go and tell their mum. So it's more the introverted type of person who seems to appreciate the SSRI effect than the extrovert. Let me tell you.
The introverts appreciate the SSRI effect?
Hang on. Well, they are the people who prefer to think about things rather than feel about them. The extrovert's much more the person who will feel about things and take risks to find out what's going on. The introvert does a lot of thinking before they take risks. And they actually find the SSRIs help. If they're maybe a parent who has kids, and let's say they've got OCD, the parent, that is, and they usually bothered when they walk down the stairs and the kids' shoes are all over the place and not tidied nicely. On an SSRI, they'll sail past this mess and they won't give out to the kids. Okay, but let me tell you an interesting story about that, which should appeal to you. At least I think it will. The man who created SSRIs was a man called Arvid Carlsson. Okay, and he was pleased that SSRIs. I should let you know, if you asked him about can these drugs cause good trips and bad trips, he said yes. These drugs are working on a normal serotonin system, and just like LSD working on a normal serotonin system, you'll get good trips and you get bad trips. So if you asked him, in a bad trip, can someone commit suicide? He'd say, yes, absolutely. Okay, but he hoped these drugs were going to be antidepressants, but recognized they weren't particularly good. He thought they were more useful for people who had obsessive compulsive disorder. But he was told by a clinical colleague one day that, we've got a bunch of patients who've got OCD who don't find your SSRIs awfully helpful. And he said, oh, really? The clinical colleague said to him, there's a bunch of people who find nicotine a lot better. And Carlsson ran a trial and concluded that, yes, there's a bunch of people who've got OCD who are much more suited to nicotine than to SSRIs. So, there's maybe a bit of a reason why people used to smoke as much as they did. It's an anxiolytic agent. But the problem for me is that you've got things like nicotine that can be anxiolytic. The benzodiazepines can be anxiolytics. The SSRIs can be anxiolytic. Some of the anticonvulsants can. But if I'm trying to explain to a patient what I want this drug to do, or what I think it's actually going to do to you, and you need to keep an eye out to see if it's doing this to you, we don't have the words for these things. We aren't able to distinguish the anxiolysis that a benzodiazepine causes from the anxiolysis you get with an SSRI, or that you get with nicotine, for instance. And given how many years we've had all these drugs and how many billions of dollars we've actually kind of spent on them, it's really amazing that we can't find the words to explain to people what we want these drugs to do. And if they aren't doing this, don't continue taking them.
Could you define for our listeners when you say anxiolytic?
Yeah. The word that we began with for this group of drugs were the tranquilizers. And people, I think, mostly understand that word. The word anxiolytic just means that they're going to cut through the anxiety you have.
Mm-hmm.
The word that came into being a little bit, but isn't used much with the SSRI group of drugs, is the serenity.
Mm-hmm.
They make you more serene. But that's just a form of anxiolysis or tranquilization.
Where do you see the future of mental health treatment going?
My worry is that doctors are going out of business, or will go out of business. Increasingly in the United States in particular, they're being replaced by nurse prescribers, or maybe pharmacists, or clinical psychologists, or whatever. And that's partly because the people who run health services, who aren't clinical people at all, look at the propaganda, which says these drugs work wonderfully well and are free of problems. And they think, but if they work so well and are free of problems, who needs expensive prescribers like doctors? Nursing staff can do it as well. And, these days in loads of parts of the United States, the mental health services are run by nurses. There's not really a doctor inside. Or if there is, they're in management. They're not actually seeing patients.
So if someone was to come to you and say, I'm feeling depressed or I'm feeling anxious in my life, this is my experience, the situation I'm living in, how would you treat them? What's the best way, do you think, to treat them?
Okay, well, let me give you a sense. Having listened to a bunch of patients over in Canada for a year before I got fired for trying to reduce the number of drugs they were on. My experience was, if I was being asked to handle the problems they were being asked to handle, I wouldn't be doing any better than they were. Mm-hmm. So I think the key point, first of all, is to say, look, you're actually probably doing pretty well. You're not mentally ill. Yes, there are issues that you actually have on your plate, but, all things being equal, you're doing as well as I would do, or maybe even better. The other point is, whatever the problems are, on average, these things only last 12 to 14 weeks. On average, people who've got the kind of problems you have, these things clear up without pills. And if you get better without pills, you're going to be more resilient in the long run. Mm-hmm. And this is particularly true, I think, for younger people. They really, I was an awfully confused teenager, but back at a time when we expected teenagers to be confused, that's part of growing up. Now we've kind of lost that, the kind of sense that people differ, they've different ways to handle things, and you learn the ways that work for you. But it's kind of tricky, isn't it? I'm slow to use the other pills. Or if I do use one, then it's very clearly after being able to explain to people what I want the pill to do and what I think the hazards could be, and trying to engage them in the process of keeping an eye on whether it suits them and whether they think it's ultimately going to be helpful. Yeah, it's a bit like nicotine. Let me come back on the Arvid Carlson thing. When Arvid Carlson ran a trial, I actually found out about this from one of my patients who had OCD, who I'd put on SSRIs, and he didn't respond at all. And he came back after some months, and he told me he'd stopped all my pills, and he was feeling better. And I was pleased, because this was an extremely nice man, okay? Then he said, but, I did some research, And then I decided to take up smoking. And I was pleased because I just wanted him to be well, and he was clearly feeling much better. Okay. And he showed me the article reporting Arvid Carlson's research on using nicotine for OCD. So that's how I found out about it. But the interesting point is this: who's in the best position is going to work out whether his best option is to take nicotine or an SSRI. Doctors on the whole will think SSRIs are the licensed treatment for nicotine. No, licensed treatment for OCD. Not nicotine. It's not licensed for OCD. But the person, this man who ended up taking nicotine, is clearly in the best position to actually decide because he knows what the SSRIs did for him, which was nothing. He can see what nicotine has done for him, which it was actually helpful. Everyone knows that nicotine comes with hazards. The one useful thing I can add in here is to tell him, if you take an SSRI and you get hooked to it and you end up on it for years and years and years, as an awful lot of people do, it also will kill you prematurely. So ultimately, it seems to me, he's the person best placed to weigh up the benefits, which he has or hasn't got, the hazards, which he may or may not get, which are roughly the same for nicotine and the SSRIs. It isn't me, and it isn't FDA who's actually best placed to work out what he should be doing.
Can you summarize that, Rhonda?
It's always the patient that should decide for him or herself what's the best treatment.
Yeah. Yes.
Yes.
Absolutely.
But also, we're not really talking about talk therapy. We're talking about should a person take medication or not. But we have other options. We have team therapy. There's a lot of research on cognitive behavioral therapy for the treatment of depression, anxiety, OCD, phobias, etc., habits, addictions, even relationship issues. That has nothing to do with taking medications.
Mm-hmm.
And so that is clearly the option, wouldn't you say, of choice? If someone is saying the SSRI isn't working and yet you're still feeling distress or they don't have the skills to cope with the stuff that happens in life, let's refer them to a therapist that's skilled.
Mm-hmm. Well, I think the issues are we've got to recognize that it needs to be the person who's actually going to be best placed to work out what will help them. Mm-hmm. And even within cognitive behavior therapy, some people are going to respond to the behavioral element rather than the cognitive element, and that needs to be recognized by therapists and isn't often recognized. They operate according to the manual and they give the patient everything, some of which may suit and some of which may not. So there's a certain degree of blind spottedness there also. Not as bad as with the pills. But one of the things that interests me most at the moment is the possibilities of using interoceptive exposure therapy if anyone's put on an SSRI. These are going to affect your vision, your balance, your sense of touch, your emotions generally. And it should be wonderful for a clinical psychologist or research psychologist. Let me take you back 130 years. And before the word psychopharmacology came into being, Emil Kraepelin, whom you may have heard of, created pharmacopsychology, which was using the drugs they had then, opioids, cocaine, alcohol, caffeine, to try and analyze behavior. Kraepelin would have died for access to an SSRI. These impact the sensory nervous system in a way that's almost beyond anything else we have at the moment and should allow us to analyze subjectivity in a way that we haven't been able to up till this. So my hope is that we'll somehow get around to getting psychologists and doctors working together again. Because if you're giving an SSRI, there's a scientific experiment happening. You may be doing therapy, but there's also science happening, which we're not exploiting. We're not looking at what's actually happening, getting the patient to report on things, and helping them to modulate things to see what then happens.
Dr. Healy, I think we could talk to you for hours and hours, and I really appreciate it, as I'm sure David does, and he'll say everything that you've said to us. We normally end about now our episodes, and I'm sure David's going to ask you, but if you could leave our listeners with one message about psychiatric medications or the treatment for their own depression, anxiety, or other mental health conditions, what message would you leave our listeners?
Yeah, I think the main thing I'd say is hardcore mental illness is very rare. We've got an epidemic of people with all sorts of diagnostic labels and on all sorts of pills that they really don't need to be on. David mentioned it earlier. We've got pills treating the side effects of previous pills that the person is on. I'd say to them that, we need to get back to having a tolerance of variation, a recognition that people differ in the way they handle things. And probably the most important thing at the moment is to get people out of the mental health system if we can, rather than try and treat them for things which are life's problems, which internalize the problem in them, when often the thing that's causing them problems is the social situation that we've all got at the moment. The world's a scary place at the moment. And yeah.
David Burns, is there anything you want to say?
Let me just finish my note here, but to kind of stay out of the mental health system, and you're not going to find your answer for the most part in drugs and pills. Some message I really resonate with. I just want to end on a personal note and just say how much it sounds kind of corny and silly, but it's just been an honor to be here and sitting in your presence and learning from you. And I've had such intense admiration for you, and this is a real highlight for me that I'll never forget. And thank you so much for coming on our show. I'll write up some show notes and send to you. Well ahead of time. I'm about a week behind on them right now because of that paper I sent you. I've been kind of obsessed with getting it done in the past week, but I'll send you some show notes. Feel free to edit them in any way you want. And also, if you have, I'll ask you with an email, if you have a picture or something we could use as the featured photo. But I just say thank you so much for giving us a tiny slice of your life, your fantastic career, your sharing your integrity, your physicianly pursuit of the truth, and for working with the patient, for listening to the patient, and for standing up against this avalanche of money-driven kind of propaganda that's in the suppression of important information. It's a sad situation in a way that our field is in, and that's why I've been working to develop our app, which is totally free to everyone. It gets 70% of patients symptom free in an hour and a half, and but as you mentioned, no one's interested in our app, even for free, even that it'll end your symptoms the first time you sit down with it, probably. Because maybe that's part of the reason. It's just, I'm not sure, but I'm sure we're going to go out of business. Sadly, for 50 years, I've dreamed about creating an app that would be able to outperform me and human therapists. And I finally have been able to create it with the help of some gifted colleagues who have come to me. But now that we've got it, seems like no one wants it, so we're kind of perplexed. But that's for another day. But it's just been a joy to meet you, and an honor, and kind of really fun and really interesting.
Let me add just one more quick point in, based on the things you've just been saying. We've left an era where the magic lay in what we were able to do for each other. Maybe pills came into the picture at some point, but the magic lay between people. The industry has been very good at getting people to think the magic lies in the pill.
Yeah.
And it doesn't. Yeah.
Yeah. Right.
I think that's really putting everything in a nutshell. The magic.
Repeat it, Rhonda. Repeat it.
There's no magic in the pill. The magic is what we create with each other.
Oh yeah.
Yeah.
Yes.
Yeah, that's right. Yeah, that's where the magic is.
Yeah, that's where God lives too. Just saying. Yeah. Okay, well, thank you so much. Really appreciate you. It's been a pleasure and a joy.
It was really great to be asked. Thank you very much.
Yeah. You're very welcome.
Okay.
We're very fortunate. So have a good one, and hope our paths cross again.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.